Alright guys, welcome back. We are going to now be diving into block 3 of NBME 18. So in NBME 18, what we've seen so far is a lot of questions on acid-base physiology, a lot of questions on protozoa, right, rather than bacteria and viruses. Of course, there were questions on bacteria and viruses as well. There was a lot of questions on the whole concept of like understanding tiny things, pretty much from biochemistry, right? Not so much of metabolism, not metabolism at all on most of the NBMEs I've seen actually, right? They don't tend to be asking questions on NBME lately about things like your glycolysis and gluconeogenesis and like that. Maybe you'll get 2 or 3 questions, but mostly questions from nutrition, questions from molecular biochemistry. Just the silly stuff you would think, like, why do I need to know this to be a doctor per se? I don't, but you do need to know it for, the exam. So that's the unfortunate world of medical school. So right now, continuing on block 3, I'm just gonna give it a little bit of time real quick while I fix something up in my videos on the other screen and let some people join. But let's see. I noticed I had the wrong block number written in the description of the videos that I did. They all say block 4 for NBME 18. Just fixing that up real quick. Okay, so alright, we could just get started now. I'm gonna do 101 to 125 right now, and then finish up the rest later on. So first question here, very straightforward question on the mechanism of action of cholera toxin, right? So cholera toxin catalyzes the transfer of an ADP ribose to an arginine residue present in the stimulatory GS protein, resulting in the inhibition of the GTPase activity of GS on intestinal cell membranes. Which of the following is the most likely to increase in these cells as a result of this process? So cholera causes very watery diarrhea, but you need to know what the mechanism through which it does it. This gram-negative, flagellated, comma-shaped, oxidase-positive, alkaline media bacteria, right? You need to know that entire characteristic of cholera like that. Activates GS to increase cyclic AMP. The answer was A here, concentration of cyclic AMP. Since it needs an alkaline media, it is sensitive to stomach acid and requires a large inoculum or low gastric acidity, such as in patients who might be taking something for GERD like omeprazole. Treatment is just with rehydration because this causes profuse watery diarrhea, and if you've done sketchy micro, then you'll be able to remember most of those characteristics because it's all actually in this the Vibrio cholerae image right up here, this one. Right, so the whole thing was these guys had these gas canisters, right? And the gas, there's no A, it just says GS to remind you of GS. And this guy, right, with the gas canister, he's holding a map for the base camp, right? And that's supposed to remind you that it's basic, it needs an alkaline media, and the camp is more for cyclic AMP. And here you can see this little raft over here is comma shaped. That's the shape of cholera, and it's actually just adhering to the lumen of your intestines. That's basically all it's doing. Profuse watery diarrhea, right? This table over here is further there to remind you of how it's actually acid labile, right? So acidity will actually kill it, and the blue ring is always a sign of oxidase positive, which is shared in all of those comma-shaped guys. Like even see Trigeminal, this guy right here is also wearing a blue ring. Right, but in this image per se, it's kind of not done being colored in, right? But there's a shared picture that shows you all the guys that are oxidase positive and flagellated, right? So the flagellation is depicted by the mustache they all have, all right? So very important details, very difficult to catch before sketchy micro, but now that sketchy's out, it's a lot easier. Okay, all right. An 8-year-old boy is brought to the physician because of persistent aching pain in the back of his head since he fell off a swing 2 days ago. So you see how it gets a little blurry when I make it too big? It's pretty annoying. He has no vision difficulties. Physical exam shows a 2.5 centimeter tender, swollen mass over the right occiput. There is no adenopathy. Neurologic exam shows no abnormalities. A CT scan of the head shows an osteolytic and soft tissue mass in the skull with mild, smooth inward displacement of the dura. A biopsy specimen of the lesion shows replacement of soft tissue by a sheet-like infiltrate of pale eosinophilic cells with bean-shaped nuclei. There are increased admixed eosinophils. So up to this point, you really should not per se have an idea of what's wrong with this guy. You're reading the question, you reach up to eosinophils and you're like, what the heck is wrong with this person? Then you read the next sentence and that should give it away to you. This is actually a pretty common theme lately in NBME. The cells test positive for CD1A or on immunostaining. Transmission electron microscopy shows you Burbeck granules, which are the tennis racket shaped granules. Most likely cause of these findings is an abnormal proliferation of which of the following cell types? Right, and then it's a Langerhans cell histiocytosis, so the answer was just C, Langerhans cells, right? So 468 shows you the whole concept of Langerhans cells histiocytosis. That's the skull lesions and stuff they're talking about. Usually affects very young children with lytic bone lesions. This is the tennis racket shaped Burbeck granules you would see. And there was another question in NBME where they asked you where these cells are derived from. Langerhans cells are dendritic cells derived from the bone marrow and found in the epidermis. Okay, so that was a slightly more difficult question because the correct word wasn't actually in first aid, right? But you have to remember it's dendritic cells. So that's Langerhans cells. Number 103 over here. A new antiplatelet agent is developed for the prevention of recurrence of stroke. In a large randomized clinical trial with equal numbers of men and women, the rates of stroke are lower in patients receiving the new agent than in patients receiving the standard treatment. Results are shown. And then you look at this and they give you women and men overall, recurrent stroke rates per 1,000 person years with standard treatment versus the new drug. Okay, so you could tell that stroke rates went down in both genders and went down overall with the new antiplatelet drug. Based on these results, which of the following is the relative risk reduction in women? Now, RRR, you don't necessarily need to memorize the equation for relative risk reduction, all right? It is very critical for step 1 that you actually understand what these calculations mean, so that you should know what the equation is. You should be able to derive it from your mind rather than have to memorize and be confused and baffled when you see a question like this. The cheat sheet we made up had all the equations there, and that would be something that you would memorize and prepare so that when you sit down for step 1, you would just write all the equations down and you'd be good to go. But before that, in this kind of table over here, the first thing you need to remember is relative risk reduction is relative risk being reduced from 1. So 1 minus RR. Okay? You're reducing RR from the 1. That's a straight up easy way of memorizing it. And then you have to remember, how do you calculate relative risk? For this kind of data, the way that's given here, it's literally just, relative. The word relative means like dividing, right? It's like a ratio, like this is half as fast as the other one, or relative to that one, I worked relative to my other coworker, I worked twice as fast, right? It's a division / multiplication thing. So relative risk from here will literally just be a division, right? So the new versus the old, what is the relative risk? And 0.04 divided by 0.12, that's actually 1/3, right? 4 over 12, 1/3. So 1/3 is your relative risk, and the reduction is 1 minus that, so 2/3, which is 67%. You just pick G and you move on. Very straightforward topic. Just Rems is asking what's a good way to increase your score. 30 points is a lot, but increase your score on step 1 2 weeks before. Well, at this point you should pretty much know everything if your step 1 is coming up. The only thing I would recommend in the final 2 weeks would be, 1, mastering that cheat sheet thing I talked about. I feel like that helped me the most. Right? There are 2 pages of that cheat sheet that you have to kind of really memorize well and then replicate when you sit down for your test, right? So this was the first page right here, and then let me find the second cheat sheet 2, right? So basically these were these were the pages I kind of put together, where these are the things you would write down when you sit down for your test. You would quickly just put it all onto that. This is still under development. As I finish through the first aid playlist, I'm going to add a couple more things to it. But these are just the mainstay of things that you kind of need to have a slight idea of before you start your test. You know, this is the acid-base stuff. This is your neurology stuff, the sleep stuff, you know, the basics like that. The other page had a couple equations from biostatistics and epidemiology, right? So you wanna be able to replicate this when you sit down for your test. Put it all down onto your piece of paper. You're gonna get 2 pieces of scrap paper. You want to put it all there. Anyone that needs that can find it on my community page, or you could email me and I'll give it to you. But it's a free thing. It's on my community page on right here. No, that's not it. Yeah, right here. So you can just go ahead and head on over to my community page. This is where I usually make announcements to my YouTubers. And you can scroll down and you'll find it there. That would be something you would memorize. And then a lot of people, I recommend, you know, in the last 2 weeks, maybe you could do the rapid review section down here. You know, go through this. It doesn't take much time. You could probably just do it in a day. But clinical presentation versus diagnosis, you know, it's a really nice thing down here, this rapid review thing. Just use it. Make sure you understand each of these clinical presentations. None of these should be something you go blank for. You just make sure you go through all of this. You can get through it in a day or 2. You know, finish that. Understand this classic relevant treatments. Right? So you should know all of these relevant treatments, because you can get questions directly about one of these, and then they ask you what the treatment is. Right? This one over here about the other microbiology stuff, right, and their treatment. Key associations are very critical. So all this stuff in rapid review, it's pretty good. You could just go through all of that in your final 2 weeks if you wish. You know, that would be nice. Other than that, there really isn't much else to do in your last 2 weeks. Make sure you relax a lot. Make sure you decide what you're going to be eating and how you're going to do your breaks. Bring something to eat. My email is at the bottom of all the videos I've posted, and it's that. And yeah, you know, best of luck. Let me know how it goes. Let me know if anything that I lectured was actually able to help you, and good luck. Alright, number 104. A 60-year-old man is brought to the emergency department because of a one-day history of fever, chills, and confusion and memory loss. He recently returned from a trip to the Gulf Coast of the USA where he walked barefoot on the beach. He has a history of severe cirrhosis and portal hypertension. His temperature is 102.2 F, so it's very high. Respirations are 22, blood pressure is low. Physical exam shows marked cellulitis of the right lower extremity with early blister formation. 1 day later, blood cultures grow a gram-negative lactose-fermenting organism. Which of the following is the most likely causal organism? Okay, so gram-negative lactose-fermenting. You look at your answer choices and there's a bunch of stuff here. You should be able to knock out some of them very, very quickly, and some others by thinking a little more. The correct answer here was Vibrio. Okay, Vibrio. And Vibrio is discussed in the book, but not Vibrio vulnificus. So the correct answer here was F, Vibrio vulnificus, a gram-negative motile curved-shaped bacillus, pathogenic bacteria of the genus Vibrio. Presents in marine environments such as estuaries, brackish ponds, or coastal areas. Vulnificus is related to cholera, the causative agent of cholera. It is extremely virulent and can cause acute gastroenteritis after seafood or undercooked oysters, necrotizing wound infections from exposure to contaminated marine water like our guy with blistering dermatitis, and invasive sepsis, another thing that occurred in our guy. Our guy also has septic shock, which is why his blood pressure is so low. Notably, V. vulnificus is dependent on the amount of iron that is accessible, making patients with liver disease prime targets, as more iron will be available for capture, and he does have cirrhosis and portal hypertension. The other answer choices, H. influenzae and Salmonella, those two do not ferment lactose. You need to know all your lactose fermenters by heart. These two are definitely not those lactose fermenters at all. In addition, H. influenzae is the EMOP, right? Epiglottitis, meningitis, otitis media, and pneumonia. None of that which fits our patient. Salmonella typhi, right, causes constipation followed by diarrhea and typhoid fever, which has rose spots on the abdomen and GI bleeds, unrelated to our patient too. Staph aureus and strep pneumo were completely irrelevant here. And on top of that, they told you it's gram negative. Those guys are gram positive. So, It's really easy to knock out a bunch of stuff based off the information that's given. Should not be getting questions like this wrong. They do this on purpose because they know Vibrio vulnificus is something you've probably never heard of if all you studied off of was first aid, right? But even if you studied only off of first aid, you have heard of the others, and you should be able to knock them out. Excuse me. So I put it up here. I added in Vibrio vulnificus as a note right next to Vibrio cholerae. Very nice to just have it in the back of your mind, especially if you've already memorized everything else, right? So now adding in new information isn't as annoying. Adding new information while you're still learning stuff is pretty annoying. Okay, so that's that. 105. During a clinical study of calcium and phosphorus metabolism, a 50-year-old man undergoes a series of lab studies. His serum calcium, phosphorus, and PTH concentrations are within the reference ranges. He's given an infusion of 2 grams of calcium chloride over 2 hours. His serum calcium concentration now is 11.5 milligrams per deciliter. Compared with the pre-infusion level, the serum concentration of which of the following substances is most likely to be increased at this time? So in the beginning of this video, I told you some of the things that are pretty popular in NBME questions. Other things that were also very popular in NBME questions have been endocrine questions, questions about Cushing, questions about the reproductive endocrine stuff from the reproductive chapter, and then all the questions about calcium and PTH and parathyroid related peptide, right? All those different lung cancers, very, very significant stuff. They love kind of asking you about this. This is another case scenario of something that isn't in first aid, right? They're telling you that they're going to give this patient a lot of calcium, right? And after giving him calcium, he's obviously going to absorb calcium, which requires vitamin D. Oh, for the Langerhans histiocytosis. Oh, you're talking about from the book itself. Yeah, they often don't really give you that in questions. In questions, they'll only just tell you the CD1A stuff. But the S100 is mesodermal. This S100 is mesodermal origin. The other thing you're thinking of, let me just make sure, because I know there are some NBME first aid erratas. Let's take a look at this. So I'm looking at the errata right now. Minor corrections. Okay, so interpretation of iron, aspirin. Like this was one that I just recently edited in my book because someone pointed it out. In First Aid 2019, they made the mistake of saying aspirin-induced tinnitus is related to cranial nerve 7. I fixed it in my version of First Aid, but just remember it's actually cranial nerve 8, which obviously makes sense. And the cluster A personality disorders, the first row of this one is actually missing paranoid. They forgot. So make sure you know that column 2 is missing pervasive distress, accusatory, a lot of silly things that are, you know, pretty significant. So make sure you have that. But they don't have anything they fixed regarding that. So no, it is S100 for S100 for mesodermal origin right here. The other S100 thing is like with melanoma, right? So let's take a look at that too, just to confirm. Melanoma is in dermatology. Yeah, right. They tell you here again S100 tumor marker, right? But that's also it's a tumor marker here, but it's irrelevant to think about whether it's mesodermal or neuroectodermal, because melanin, right? You don't have to worry about that aspect for this stuff at all. But I'm trying to remember where else they actually mentioned the S100. It was somewhere general too, but I can't really remember. Let's see if it pops up. Yeah, right here. Right, so this is why you're probably asking, because the neurocrest cell stuff, right? So important immunohistochemical stains, S100, melanoma, schwannoma, Langerhans cells, histiocytosis, all three, right? S100. But the neurocrest cell stuff, you don't associate S100 with neural crest cell. It's just more so the fact that for melanoma and schwannoma is the main association there. Yeah, good question. Alright, so right here for this question, where they're giving this guy a bunch of calcium, you're going to need active vitamin D to absorb the calcium, and then it makes sense that once you have absorbed the calcium, that active vitamin D is going to become inactive vitamin D. You look at all your answer choices, and you're like, what the fuck is happening here? So page 70 discusses vitamin D. This one, 7-dehydrocholesterol, is the initial thing that we convert into D3 with sunlight, while D2 is what we mainly ingest, right? So that's D3 right here. They don't have D2 as an answer choice. The liver is the one that makes 25D, and they don't have that here. 25-dihydroxycholecalciferol, they don't have that as an answer choice, while the kidney converts it into 125-dihydroxycholecalciferol, right? And they don't have that. That is an answer choice here, B, right? A lot of people actually did end up picking B as an answer because they identified it and they're like, maybe this is going to be high, but that's actually the wrong logic, right? Why would that be high? That's active vitamin D. So if anything, choice B is going to be low. The active vitamin D is going to get metabolized and used up as it does its job to help you absorb calcium. First aid doesn't mention this, but 24-25D, right, this one, the correct answer, 24-25-dihydroxycholecalciferol, is the inactive metabolite that we excrete after using vitamin D, as would be the case for our patient here. These guys ate a lot of calcium, so they'll use vitamin D to absorb it and then excrete the inactive vitamin D. Pre-vitamin D3 is an intermediate created by UV exposure. Right, so those were all the answer choices there. You should be able to, have that critical thinking capability and kind of knock out the answer choices that really don't make any sense and then pick the correct stuff. So I did add it here. I wrote the inactive metabolite of vitamin D is 24-25-dihydroxycholecalciferol, which is what we excrete after absorbing calcium. Right, and this image is what UWorld gives you. Right, so it's a pretty good picture. It is incomplete, but it's a good picture. You have your 7-dehydrocholesterol. That works with ultraviolet light. You make vitamin D3, which is cholecalciferol. Right, D2 is ergocalciferol, which is what you eat. So it starts with an E. Both of those in the liver become 25-hydroxyvitamin D thanks to 25-hydroxylase. And if you have liver issues, you won't be able to do that. If you have kidney failure, you won't be able to do this part. 1-alpha-hydroxylase makes it into 125-dihydroxyvitamin D, which is actually active. That goes everywhere, and then in the intestines, right, it increases calcium absorption and phosphate absorption, and you then convert it into 24-25-dihydroxycholecalciferol, which is inactive, and you excrete that. Okay. Keep in mind also that vitamin D and PTH, although they might look like they're opposites, they are actually partners, right? This is something I discussed when we did the endocrine videos. They work together. PTH is phosphate trashing hormone. You throw out phosphate and you retain calcium, right? But that's only in the kidney. PTH also activates vitamin D so that you can reabsorb the phosphate or absorb new phosphate. Not reabsorb, but absorb new phosphate. When you piss out the phosphate from your kidneys, that's gone. But PTH allows you to absorb more phosphate to replenish it, right? So they do work together. PTH and vitamin D are partners. They work together. Everything in our body works together. Also keep in mind vitamins D and K, right? You can't really get in breast milk. So those are things you have to give to an infant in the beginning. Just little information like that. You can get questions on that on NBME. A 10-year-old boy is brought to the physician because of a 4-day history of nosebleeds and easy bruising. 3 weeks ago, he had an upper respiratory tract infection. Physical exam shows ecchymoses over the upper and lower extremities. Lab studies show a hemoglobin concentration and leukocyte count within the reference ranges and a decreased platelet count. A bone marrow smear shows an increased number of megakaryocytes. Which of the following platelet abnormalities is the most likely cause of the findings in this patient? So, nosebleeds, easy bruising, ecchymoses, these are all a giveaway. These are all a giveaway for the fact that this is something related to platelet issues, and then they confirm that it's a platelet abnormality. And this is a classic scenario of immune thrombocytopenia, right? He just had an upper respiratory infection. Right? They just told you that 3 weeks ago he had an upper respiratory tract infection. This is a classic case of anti-GP2B3A antibodies causing splenic macrophage-induced phagocytosis of platelets after a viral illness. Labs always show more megakaryocytes on bone marrow biopsy, and the platelet count decreases. Give steroids, IVIG, rituximab, or TPO agonists. The other two diseases, Buerger disease and IgA vasculitis, are two differentials that are very close to what happens here. Right, so let's take a look at both. Page 459 is your actual thing, what we're looking at, immune thrombocytopenia. Right, so destruction of platelets in the spleen thanks to anti-GP2B3A antibodies. Right, you're not going to have any GP2B3A activity, very similar to Glanzmann thrombocythemia, where they don't even have it in the first place. Right, the main difference is, though, that in here, in immune thrombocytopenia, you start noticing the increased megakaryocytes on bone marrow biopsy. Right, that's the main thing you start seeing here that helps you differentiate from Glanzmann, and then of course history of any kind of viral illness or malignancy, drug reactions. It can be any kind of weird connection they try to make. Right, so that's that. The other differentials you have, IgA vasculitis and Buerger disease, those are in cardiovascular path. So if we look at that, Buerger disease, right, most common glomerulonephritis worldwide, presenting history is nephrotic syndrome, acute kidney failure, and chronic kidney failure. There is IgA vasculitis and IgA deposition in the glomerulus, which presents with hematuria, and our patient didn't have that. Okay, so hematuria would be the Buerger disease thing, but it's also related to upper respiratory infection. Right, presents with hematuria 2 days after non-specific upper respiratory infection, so it has to be something. It's not the post-strep glomerulonephritis. It's some kind of like viral infection causing hematuria. Right, so very, very difficult topic to catch in most questions, to be entirely honest. And then IgA vasculitis itself, this also follows an upper respiratory infection. Right, this is the one called henoch-Schönlein purpura, and you have a classic triad of skin purpuras, arthralgias, and then abdominal pain. Right, some upper respiratory infection caused excessive production of IgA for your gut lumen, and it's going to end up depositing everywhere, including the glomerulus. The involvement of C3 to C3A, which is a potent anaphylatoxin, will recruit white blood cells to release histamine, increasing capillary permeability, leading to red blood cell extravasation. This is a type 3 hypersensitivity in the small vessels. Condition is self-limited and resolves as the immune complex is clear. Right, whereas the other two guys will not resolve by themselves. Buerger disease and our question, immune thrombocytopenia, those things do not resolve by themselves. So very closely related pathologies over here. Thin line between the differences between them, so be careful in picking one over the other. You might have all of them as an answer choice. And I'm not 100% sure, Meher. I would have to check that because I can't remember if UWorld actually even had a good question on Langerhans cells histiocytosis, because when I was putting together notes, I didn't really put together any UWorld questions for that topic. Alright, so Langerhans cells, I don't have a question on Langerhans cells here. Yeah, so I'm going to check that. Cells express S100, mesodermal origin. I'll make a note of that and make sure I take a look, and then tomorrow's video, or the next video after this one where I do the other half of block 3, I'll make sure I reference that out. So let me make a note real quick. Okay, I'll come back to that. Alright, so now last one on this page, page 107. This was also pretty interesting. Not that hard though, but a lot of people did get it wrong. 22-year-old man who is a professional cyclist undergoes extensive physiologic testing as part of his training regimen. His resting pulse is only 33 per minute, which is pretty low. Blood pressure is 110/62. Echo shows dilated ventricles with normal function and a left ventricular ejection fraction of 75%. Which of the following best describes the findings in this patient? So since he's a hardcore athlete over here, right, it makes sense that his pulse is so low and his ejection fraction is so high. His heart is beating very well, and each beat sends out more blood than the average human. So he's doing pretty good. That's actually really, really good. None of this is pathological. Okay, so dilated ventricles. So now they're asking you what describes his findings. Since this is not pathological, you should not get any answer choice that is regarding pathology. So the other answer choices are pathological. The correct answer choice here was C, eccentric hypertrophy. A, congestive cardiomyopathy. B, diastolic dysfunction. D, hypertrophic cardiomyopathy, right? And then E, increased myocardial stiffness. These are all pathological things. They're not normal. They're not physiological adaptations. So they're all wrong answers, right? So it had to be eccentric hypertrophy, C. Which is what happens when you work out a lot and your heart is working really, really hard, right? Eccentric hypertrophy is what we see in dilated hearts, right? And they told you it was a dilated heart. But his heart isn't dilated due to dilated cardiomyopathy. He doesn't have cardiomyopathy. His heart is dilated because he works out a lot. So his heart is adding more sarcomeres in series, not because of any other issue or disease, but also only because he works out a lot. He's a strong guy, okay? It's never going to be this thing. It's never concentric hypertrophy. Remember, if you're doing concentric, you want to remember you're taking a circle, putting another circle, and until the lumen gets really thin, and that is, concentric, circle, a lot of cylinders being added on top of each other, and it makes the lumen really, really tiny. This is not something an athlete can actually survive with. It's actually the opposite. Athletes with this disease die, right? So that's the scenario you usually see with hypertrophic obstructive cardiomyopathy. So they didn't even have that as an answer choice. They didn't have concentric hypertrophy as an answer choice, but that would have been a more mean answer choice to have than anything else. 108. A healthy 5-year-old boy is brought to the physician by his parents for a well child exam. He has a history of motion sickness. Physical exam shows no abnormalities. Parents are planning a vacation to Australia, and they ask the physician if they should give their son diphenhydramine during the trip for his motion sickness. Which of the following is the most likely mechanism of action of this medication for motion sickness? Okay, so first of all, if you remember diphenhydramine, right, then you remember it's an H1 blocker. So you immediately know answer choice D was just there to bait you, right? H2 antihistamine, they even wrote it there, histamine. Antagonist at histamine H2 blocker, that is cimetidine, those things, the H2 blockers that you use for acid release, right? Dinner for two, so that's immediately one answer choice you can knock out. Now, how does diphenhydramine help with motion sickness? So this question was actually kind of bullshit because I'm not 100% sure about this, but a lot of people were arguing about this, and I agreed that, the correct answer here is E, antagonist at muscarinic M3 receptors, but it should actually be M1 for vomiting and stuff like that, right? Motion sickness, because scopolamine and many other medications that you use for motion sickness all work through M1. So why is diphenhydramine, or how is diphenhydramine helping with motion sickness through M3? Right? So a lot of people actually didn't pick answer choice E because they saw the M3 thing, and then they went with other things like either F or one of the A or B. Now, A and B definitely don't make any sense. Alpha 1 and Beta 1 don't have anything to do with motion sickness. It's just irrelevant. If we go look at diphenhydramine, and you try to not think too much about it, okay, here, vomiting center, right? So if you're looking at vomiting, they tell you here, M1, H1 and M1, right? So this is one way to actually understand that it is M1. And whoever posted, there were a bunch of people arguing that it shouldn't be M1. So it shouldn't be M3, it should be M1. I told him, yeah, it makes complete sense because here it doesn't say M3. Right? You can see vomiting center, nothing about M3. So it might have actually been a mistake by the test writer to put M3 as an answer choice. It should have been M1. But just remember that diphenhydramine actually helps as a muscarinic antagonist, and that's all you really need to care about, right? If you remember it's a muscarinic antagonist, and you only see one answer choice that's a muscarinic antagonist, just pick it. Like, the others are not going to be of any relevance. Diphenhydramine is actually discussed all the way in respiratory form. It's the first medication, and reversible inhibition of H1 histamine receptors, diphenhydramine, all these other ones. Allergy, motion sickness, and sleep aid, right? The anti-muscarinic effects are urinary retention, dry mouth, blurry vision, and delirium. The anti-alpha adrenergic effects are hypotension and dizziness. Caution with older patients. Okay, the second generation ones are preferred a little more because they have far less sedation because of decreased entry into the CNS. So loratadine is a very common medication a lot of people take. Cetrizine as well. So just know these. These are all medications generally people hop onto when they have severe allergy. 109. X-ray of a newborn shows ribs associated with the 7th cervical vertebra. Okay, this question I didn't even bother, but I did get this wrong, so I definitely want to put that here. I did get this question wrong. Why is this back there? Alright, this one I didn't get correct because although I knew what Hox genes are about, this just didn't make much sense to me. I put for this one A. Sorry, not A. I put B. I put B for this one. So let me just write that down. So I got this wrong. This is the 5th question I've gotten wrong on this NBME test. This one says X-ray of a newborn shows ribs associated with the 7th cervical vertebra. So he has ribs that are associated with the 7th cervical vertebra. This apparent transformation of the 7th cervical segment to a thoracic identity may have resulted from which of the following alterations in Hox gene expression at the 7th cervical level. Right, so Hox genes are there to give you an identity. That's what they kind of do. I always remember them as identity hacks, right? Identity Hox. So hacking your identity. So identity Hox genes, they just give you every part of your body. They give it an identity so that it knows what it's supposed to do. And also the boxes, Hox box, it helps you kind of understand compartmentalization. That's another job it basically does. The choices are all about Hox genes, which should remind you of boxes which compartmentalize us. The 7th cervical segment became a thoracic segment because of a Hox gene at the caudal section. Hox genes go in a craniocaudal direction and determine segmental identity. C makes no sense, and D and E are not the correct way to discuss Hox genes. But I could have written the same explanation to you, telling you that cranial is the correct answer, and you would believe that too, because there's really no logical thing to this. Hox genes do work from the craniocaudal direction. They work in the craniocaudal direction, so I felt like cranial was the correct answer there. But this was actually, let me just check that one more time, because I was pretty, only in caudal direction. That was the correct answer, right? This person who put this explanation together also chose cranial, right? So that made me feel a little better, but the correct answer, this is wrong, the one that's in the book. The correct answer is this: expression in the caudal, normally expressed only in the caudal area. And your book tells you, right, Hox genes involved in segmental organization of embryo in a craniocaudal direction, code for transcription factors. Hox mutations give appendages in the wrong locations. And let me just see what I have a couple more notes in my book too. 665. So right here, homeobox genes, right? You mentioned something about homeobox being a highly conserved DNA sequence about 180 nucleotides in length. And that was actually really stupid too. This URL question didn't mention Hox genes. They told you there were these DNA sequences that were about 180 nucleotides in length, and you had to know they were talking about Hox genes just based off of that. So that was silly too. But ever since I got that question wrong, I remembered it. The rest of these you should know pretty well too, because embryology is a topic NBME likes picking on. Reproductive embryology mainly from first aid. That's the only embryology we really have. Renal embryology as well. That's the other one that's pretty significant. But all in all, very unnecessary question. Alright, but just remember, if there is any kind of question like this, the answer is the one that's caudal. I don't know. I guess that's the way I'll solve questions like that from now on. 110. Persons at risk for severe influenza are vaccinated every year because of antigenic variation. This variation can either be a result of antigenic drift or antigenic shift. Changes in the antigenic composition of viral proteins. Which of the following is the most likely genetic mechanism of an antigenic shift? So shifting is shifting segments, right? And that's just reassortment. That's how you have to remember that. You have to remember the two different guys. Whereas antigenic drift is doctor drift, and that was taught by Sketchy Micro. In doctor drift, the word doctor, instead of a C, is spelled with a K, right? So it's a point mutation. That would be answer choice C. Genetic shift is a reassortment of genomic segments, which gives the human swine flu virus combination, for example. Genetic drift is a random mutation in HA or NA hemagglutinin neuraminidase genes. This one could be a point mutation or frame shift mutation or any real mutation for that matter. Page 174. So let's take a look at that sketchy microimage real quick too. Alright, so you have your influenza, genetic or antigenic shift versus drift. Shift causes pandemics. This is the major one, right? Pan being the whole thing. Reassortment of viral genome segments, such as when segments of human flu A virus reassorb with swine flu A virus. Right, that's a really big issue. Genetic drift just causes epidemics, so it's more local. It's minor, changes based on random mutations of HA or NA genes. And you can see that on the wall over here, right? So Dr. Drift is spelled wrong with a point mutation. The C became a K, right? And this is actually just saying doctor now, spelled incorrectly. Whereas shift, you can see the way shifting occurs is you're actually going to be replacing these N and H's with other N's and H's from other organisms, other species. The rest of this is just more information on stuff you have to remember for influenza virus. Most notably, everything else here is pretty easy to remember. Most notably, though, we have the Campylobacter bear here. So that's a little connection they love testing you on. I forget what they mentioned. Yeah. See, patients at risk for fatal bacterial superinfection, most commonly SRS, pneumonia, and influenza. That's something you get tested on. They don't mention it here, though, right? Not in the book. Yeah, so let me see what it was about that. I forgot. Orthomyxovirus. 8 segments, so that helps you remember that is a reassortment of segments. Oh yeah, see over here, don't forget that influenza is also associated with Guillain-Barré syndrome's ascending paralysis with CSF findings of high protein and low white blood cell albuminocytologic dissociation, right? High protein, low white blood cells. This is shown by the same bear from Campylobacter jejuni. Right, so that little association in Guillain-Barré is relevant here with influenza virus. They don't mention it in first aid, but Sketchy taught it, and I can totally see that being a question. So that wasn't a hard question, though. 110 was pretty easy, just straight up memorization. When 7-year-old boy is about to undergo an appendectomy, an IV catheter needs to be inserted, but the patient is extremely fearful of being stuck with a needle while awake. The most appropriate anesthesia, administered by mask to anesthetize this patient quickly, would have which of the following characteristics? I was really happy to see this question here. A lot of people got this wrong because many people don't quite understand anesthesia that well. But we just spoke about it a couple days ago when I did the neuropharm section. So we talked about all the different things about anesthesia on that page, right? So let's just take a quick look at that. This question, though, was a straight question from the book. So anesthetic principles: drugs with low solubility in blood have rapid induction and rapid recovery time, which is kind of what we need for our patient, right? So low blood solubility was the correct answer here. This came straight from the book, right? They didn't even make it more complicated than it needed to be. Very straightforward. Never let these questions discourage you. If the anesthesia, if it is blood soluble, it will stay in the blood and have a slow onset, so more of the anesthesia will be needed to change the partial pressure, right? Always remember that. It's a logical thing. You have to be able to derive this information from the logic, and logic is what you have to learn. You have to learn the logic of how anesthesia works. So anesthesia, if it's blood soluble, it stays in the blood, so you have to first saturate the blood, right? Fill the blood up with anesthesia, then the rest of it will actually go other places. So you would need more. That's not what we're looking for our 7-year-old boy. A low blood solubility means the partial pressure rises and falls fast, so you get anesthesia and recover fast. And we're talking about partial pressures because this is a gas, right? This anesthesia is an inhaled anesthetic, it's a gas. Lipid solubility is directly related to potency, right, or dosage, rather than the induction and recovery time. Lipid solubility basically tells you how quickly the anesthesia can cross the blood-brain barrier. If it has high lipid solubility, it will immediately cross the blood-brain barrier, so you don't need to give a lot of it, right? You just give a small dosage. If it has a very low lipid solubility, it's going to cross the blood-brain barrier very slowly, so it's going to take a long time to get through, and you have to give a higher dosage for that. Very important stuff to understand, right? High arteriovenous concentration, high blood gas partition coefficient, or high solubility in the blood all of that means you're going to have slow onset because it stays in the blood, right? So you would need to give more until it finally gets to the point where it causes induction of anesthesia. Spend a little bit of time, right? All the notes are here, and you can kind of really master this kind of stuff because this is like one question. It's really not the biggest deal. And I guess this would be the one question that you would be opting to get wrong if you don't really want to spend time mastering this. But it's really not that difficult. Anesthesia is pretty cool. It's just a mechanism thing. You can definitely learn it, and you won't get any of these questions wrong. 112. This was a very easy question too, right? This one, you can look at the pictures and you immediately know what's wrong, and you could just pick an answer choice without even having to read any of it. So, a 67-year-old man is brought to the physician by his wife because of a 1-year history of progressive difficulty riding and walking. The patient is stooped and talks slowly. Physical exam shows a bland facial expression. There is a fine resting tremor in both hands, but not in the lower extremities. The tremor is not apparent when the patient is moving. When asked to walk, the patient has some difficulty starting and stopping, which is all, the magnetic gait and all that stuff. There's a cogwheel rigidity in all extremities. Testing of postural reflexes shows moderate retropulsion and mild propulsion. They're trying to make it as confusing as they can. Don't even need to read the whole thing. They tell you now the midbrain on the left is in normal control. The inclusion indicated by the arrow is predominantly composed of which of the following substances? So this is normal midbrain, and his is missing the substantia nigra, which is pretty much diagnostic of Parkinson disease. And this little pink circle inside, that's your alpha-synuclein, right? The right gross image shows a lack of pigmentation in the substantia nigra pars compacta. Symptoms listed are all of Parkinson as well. You note Lewy bodies, which are intracellular eosinophilic inclusions composed of alpha-synuclein. This is the only place you ever see something like that. You never see that kind of inclusion anywhere else, right? Parkinson disease, Lewy bodies made of alpha-synuclein. They're intracellular eosinophilic or pink inclusions, like that. Okay? So that's what they're showing here. 113, a 25-year-old woman with polycystic kidneys has a 3-month history of progressive weakness and fatigue, headaches, hypertension, loss of appetite, and itching. Her serum creatinine concentration is 4, which of the following lab abnormalities in serum is expected in this patient? Many people tend to get this question wrong. This is a very interesting thing. Logic, right? You always have to answer questions like this and acid-base physiology related. Endocrine and acid-base physiology, you have to make sure you do this logically. This patient has secondary hyperparathyroidism, secondary to renal failure. Since this patient has renal failure, she will not reabsorb bicarbonate. So bicarbonate has to be low. So now you're just between A, B, or C. You knocked out half your answer choices. PTH will try to trash phosphate, but not be able to. So you release more PTH. So PTH is going to be increased. Now this is where people mess up. When people mess up, right, people think, okay, PTH increased, so that means phosphate will be decreased. And then you pick A and you move on, and that's the wrong answer, right? Don't do that. Keep thinking with the same logic. Right now, you just said that PTH is going to try to throw out phosphate, but it won't be able to, right? So that's why you're releasing more phosphate. The reason it won't be able to is because your PTH receptor in the kidney is not working. You have renal failure. So since PTH is not working, your phosphate will also be high, right? And that's answer choice C. This is secondary hyperparathyroidism, where the two things are not opposites, they're both the same. Everything is increased. You're releasing a lot of PTH, but the PTH is also not doing its job, so you have a lot of phosphate. Right, so that's something you want to make sure you're careful with. A lot of people fell for answer choice A. Of course, bicarbonate is going to be low. Of course, PTH is going to be high because your kidney isn't responding to PTH, so you keep secreting more. And then they mess up the logic. Right now, so far, they were thinking, oh, kidney's not working. Now, all of a sudden, kidney's working in their brain. And they're like, okay, and then since we're releasing PTH, you're going to have low phosphate because your kidney is actually responding to PTH all of a sudden, right? So that's the wrong logic there. That's the way you don't want to think. Make sure you catch yourself if you do that. This is secondary hyperparathyroidism. And in secondary hyperparathyroidism, things are not the way you would expect it to be. And that's kind of what this table teaches you, right? 369 over here. This table shows you how this way, in the linear direction like that, you have primary things, right? So your PTH is high, right? PTH is high, and so is your calcium. Your PTH is super high, so is your calcium. Those are things where it's all pretty much straightforward. PTH is super high, calcium is high, phosphate is low. In secondary hyperparathyroidism, where you have vitamin D deficiency, or maybe you're not eating any calcium, or you have chronic kidney disease of any type, in that scenario, your PTH is super high, but your calcium is not increasing, and you're not throwing away your phosphate. Very important to remember that. Okay, don't mess up that logic. Very easy to fall into that pit. It's a trap. Okay, 115. This was just straight up pulmonary hypertension, and they actually have two questions on pulmonary hypertension. Another one coming up very soon in the same block. Previously healthy, 35-year-old woman comes to the physician because of a 3-month history of progressive shortness of breath with exertion. Her respirations are 26 per minute. Physical exam shows jugular venous distension with a prominent A wave. The lungs are clear to auscultation. Cardiac exam shows a loud pulmonic component of S2 and a right-sided S4 gallop. This patient's condition most likely involves an increased pulmonary expression of which of the following. And the only answer choice you could possibly pick was endothelium A. 1. Answer choice A. Like nothing else really made any sense or fit the scenario, right? The loud S2 component is due to the loud P2 closure, and you might see wide splitting due to delayed closure of P2, right? You want to make sure you understand that. So if you don't, you go back to your page in cardiovascular where they discuss splitting. The S4 is a sign of lack of compliance, possibly due to compensatory right ventricular hypertrophy. Remember that S3 is a sign of heart failure, and S4 is always a sign of stiffness, lack of compliance. She also has JVD due to blood backing up on the right heart. Remember that on the right heart, you functionally don't have any valves. Above the right atrium, there's nothing, right? You only have that tricuspid valve between the right atrium and right ventricle, and that's generally it, right? Then the pulmonic valve is just entering into the lungs. That's a whole different concept there. Once you see your answer choices, only A makes sense, and that's it. I'm going to jump over from here to the other pulmonary hypertension question because it's actually very similar. This one, 45-year-old, comes to the physician for a pre-employment examination. He has a 10-year history of hypertension and does not adhere to his medication regimen. His temperature is 98.6, which is normal, pulse is 80 per minute, respirations are 14, and blood pressure is high, 160 over 100. Cardiac exam shows that the apical impulse is displaced laterally. A loud S2 and an S4 gallop are heard on auscultation, just like our other patient. Echo shows thickening of the left ventricular wall. The most likely mechanism causing the changes in this patient's left ventricle is best represented by which of the following sets of findings in cardiac muscle. So they're saying there's left ventricular hypertrophy, right? And if there's left ventricular hypertrophy, you look at your answer choices and you're like, what the fuck is factor C Jun, right? Never heard of that. But whatever it is, we're going to take our bet. That's what I did. I was like, whatever it is, you're probably transcribing it and making it because hypertrophy is growth, right? So you're making something. So I chose to go with increased factor C Jun. So now you're between A, B, and C. Beta myosin heavy chain will definitely be high. You're making it. And then they put endothelium as an answer choice too, and I was like, endothelium, does this guy have pulmonary hypertension? And I saw the loud S2 and the S4 gallop, and I was like, yeah, endothelium is going to be high too, just like the other patient, and that's what it was, right? So this was A. Everything is high. And then I looked up what transcription factor C Jun is. Generally speaking, transcription factor C Jun is just related to cellular proliferation. It's not really the biggest deal. You don't actually need to know it. This is just NBME being fancy, but it's just related to cellular proliferation. It was mainly mentioned in this Wikipedia page with relation to endometrial lining every time menstruation is occurring, but that's just silly stuff. But keep in mind, the whole loud S2, S4 gallop, right? Those are things that you see in pulmonary hypertension. So 2 questions pretty much back to back. 116 was a nice question. This one had me thinking for a little bit. 30-year-old woman comes to physician because of a 2-year history of episodes of numbness, blanching, and a bluish color to her ears, fingers, and toes following emotional upset or exposure to cold. Her vital signs are within normal limits. Physical exam shows no abnormalities. It is most appropriate for the physician to advise the patient that she should avoid taking which of the following drugs. And then you look at all your answer choices and you're like, what the heck's happening here? Well, first of all, this patient has Raynaud disease, right? She has idiopathic Raynaud phenomena, which is called Raynaud disease. It would be Raynaud syndrome if it was due to something else like lupus or any other kind of condition. In Raynaud disease, you know that the issue with exposure to cold or emotional upset is that you end up getting vasoconstriction, right? You also see Raynaud in smokers sometimes, right? Because the vascular damage from smoking. So vasoconstriction occurs. So in that case, it would be bad to give her any other medication that can cause vasoconstriction, of which the only answer choice would be phenylephrine. Ibuprofen and acetaminophen are just pain medications we all should be very familiar with and have taken at some point. Dextromethorphan is what I've been overdosing on every day because that's a cough suppressant, so that's not an issue here. Diphenhydramine is just your typical H1 blocker with anti-alpha effects and anti-muscarinic effects for vomiting, right? And that might actually help this patient because the anti-alpha effects means that it has anti-alpha 1 effects, so it won't cause vasoconstriction. Keep in mind also that Raynaud disease is treated with calcium channel blockers, which is for vasodilation. Right? So you want to avoid things that would cause vasoconstriction in such a patient. And that was basically all that question was testing you on. Right? So right here, phenylephrine, alpha 1. Norepinephrine is also alpha 1. The only thing, epinephrine prefers beta, but at higher doses, it can work on alpha as well. Okay, alpha effects predominate at higher doses. And that's significant information you need to make sure you remember. Epinephrine is the only one that's kind of unique in that way. Norepinephrine and phenylephrine worked the same way. Alpha 1, then alpha 2. And that's basically it for that. Raynaud disease is discussed on page 518, right? Musculoskeletal. And that's right here. The Raynaud phenomena looks like this. So you can see her bluish finger here. The other ones that are pale because of lack of blood supply. Right, decreased blood flow to skin due to anything. Some kind of vasospasm due to anything, cold or stress. It's Raynaud disease if it's idiopathic, like in our patient, or it's Raynaud syndrome if it's due to some other thing. Right, and our patient didn't have any other thing as far as we know. Treat with calcium channel blockers. Okay, so vasoconstriction is the main issue in these patients. This was a very easy question too. 32-year-old woman brought to the emergency department by ambulance from a fall from a 10-foot ladder. Physical exam suggests severe hemorrhage and shock. X-rays show fractures of the left 9th and 10th ribs. Which of the following organs is most likely injured? And it had to be the spleen, nothing else really. Right? Your spleen is right there, and the left 10th and 9th rib or whatever, those ribs. What else could they really damage? I mean, we're talking about ribs, which are in the front. Your kidneys are in the back, right? They're actually attached to your posterior wall, so it couldn't be kidney. And your adrenal gland is right on top of the kidney, so you knock that answer choice out too. Your stomach is a little more medial, and it's very safe. It's strong. It's held in place. Couldn't be the stomach. The spleen, however, is prone to injury, right? From contact sports, if you have splenomegaly, car accidents, any kind of issue, your spleen can be knocked out from a good punch to that side of your body as well in a boxing fight. So very easy to knock the spleen out of place and mess it up. She just fell from a 10-foot ladder, so that's good enough too. 45-year-old man. Oh, we did this question. That was a pulmonary hypertension. All right, 119. This was also just straightforward. Like I pray everyone get a question like this on their step ones. It's super easy. 63-year-old woman comes to a physician because of a 2-week history of daily episodes of severe, lancinating, left-sided facial pain. The pain, which occurs suddenly and lasts 30 to 60 seconds, shoots from the left ear down along the jawline, right? The pain is sometimes precipitated by chewing or brushing. Vital signs are normal. Physical exam shows no abnormalities, except for moderate dental caries. What is the most likely diagnosis? She has trigeminal neuralgia. Very obvious. Give her carbamazepine. You're good to go. Common triggers are chewing, brushing, anything like shaving. If this was a male patient, shaving would be another trigger that can cause trigeminal neuralgia. So make sure you can cast that. These other answer choices do not fit at all. It's not a cluster headache. Her issue is not a dental abscess. She doesn't have temporal arteritis. Temporal arteritis is more so related to blindness and headaches, which, she doesn't have headaches. She has facial pain. Temporal lobe epilepsy doesn't make any sense. So TMJ, temporomandibular joint syndrome, was the only other possible differential you could maybe fall for. But this question was classic. They gave you everything. The precipitation from chewing, and the pattern in which it went down the jawline, all of that was classic trigeminal neuralgia. 120, 56-year-old man comes to the physician because of vague right-sided flank pain and a 7-pound weight loss over the past 6 weeks. There has been no recent trauma or strain to his back. He has no history of genitourinary problems, but his urine has been darker than usual over the past 2 weeks. So that's hematuria. Physical exam of the back shows no abnormalities. Renal ultrasonography shows a 1.5 centimeter solid mass in the upper portion of the right kidney. Microscopic exam of urine shows 50 erythrocytes per HPF, 6 leukocytes, and no bacteria. Which of the following is the most likely diagnosis? So they kept telling you that his back is okay, which was really critical, right? Because anyone else presenting with hematuria, if they also have back pain, then you start thinking maybe they have prostate cancer, which can metastasize to the back, and maybe it went to his kidney also, right? That's where you would pick answer choice A. But since there's nothing else wrong with this patient and no other possible kind of cancer is, being denoted in this question stem, you can knock out answer choice A. This isn't a renal abscess. That's not the 1.5 centimeter solid mass you're seeing in the upper portion of the kidney. Transitional carcinoma is related to the bladder, possibly the ureter, right? So that's not what's happening with this guy either. So you're really down to C and D, right? Renal cell carcinoma or renal parenchymal hematoma. And this 56-year-old man most likely has renal cell carcinoma. The patient clearly has a solid mass of the right kidney, and the only answer choice that fits that is B. A is not plausible, and E is related to the bladder. An abscess or subcapsular hematoma would not present in this manner. An abscess would be an abscess, so that's a whole different thing. That would be infection-based, his fever would be there, none of that is given. For the hematoma, subcapsular hematoma, if you actually search it up, you can find really nice pictures of what that looks like. And let's see. So it kind of looks like this. Let me put kidney. Right, so you're going to see subcapsular hematoma. So you see how this left kidney has a subcapsular hematoma? So the capsule has expanded and there's a hematoma inside of it. Right, you can see it on either side. That's not what we saw in our explanation. Our question is talking about a solid mass. Okay, so that was just irrelevant and good bait of an answer choice. 121 was very easy too. Straight up musculoskeletal anatomy. 26-year-old man is brought to the emergency department by ambulance 2 hours after injuring his right arm during a skiing accident. His right upper extremity is immobilized in a sling. Sensation of pinprick is absent over the lateral aspect of the shoulder right here, which you should always remember that little patch of skin right here over the deltoid is sensory innervation there is to the axillary nerve. An x-ray of the right shoulder is shown, and I made the red circle around it to show you where the fracture is, right? So that's your surgical neck of the humerus. And damage to which of the following nerves is most likely present? Well, you already knew the answer after looking at where the sensation is missing. It had to be axillary nerve. Right, page 482. So, axillary nerve, right? Surgical neck of the humerus, fracture. Just like our patient, you're going to have a flattened deltoid, unable to abduct the arm, right? You won't be able to abduct the arm above 15 degrees shoulder because the deltoid isn't going to be there. That's related to the SALT STDs, right? Suprascapular, axillary, accessory, and long thoracic. That's your SALT. STDs is the other way around: serratus anterior, trapezius, deltoid, and supraspinatus. Supraspinatus, right, which is one of your sits, the most commonly injured rotator cuff muscle, only helps up to 15 degrees. After that, the deltoid has to do it. And in the latter portion, up to after 90 degrees, once your deltoid makes you get to 90 degrees, then the trapezius can help, and the serratus anterior can help from there on as well. Okay, so our question was very straightforward about axillary injury, and the axillary nerve has sensation right here, that brown patch. 122, a 28-year-old man with ulcerative colitis comes to the physician for a follow-up exam. He underwent a partial colectomy 6 months ago, and his diarrhea and rectal bleeding have markedly improved since then. Current medications are mesalamine, which is a treatment for ulcerative colitis, and hydrocodone and acetaminophen, which are for pain. He lives with his parents, and his academic progress has been slowed by multiple hospital admissions. He is now attending college part-time and has been working part-time as a pharmacy technician at a local drugstore. He says, "I've been taking so much of my opiate prescription that I ran out and stole some from my job. They caught me last week, but I haven't told my parents yet. Which of the following is the most appropriate initial action by the physician?" So he did a bad thing, right? But you're not a police officer. But he did do a bad thing, so let's see what you're supposed to do here. The correct answer was A, but let's look at the others first, right? So tell the patient that he needs to find a different physician since he broke the physician's trust regarding his pain medications. False. That's silly. That's childish. That's stupid. C, contact the Drug Enforcement Administration and report misuse of narcotics. No, this patient has ulcerative colitis. He needs it. He actually does need it. He might be addicted a little bit, but that's just the expense of needing opioids. Like, if you need opioids, you will get addicted to it. But he actually needs it. Contact the patient's parents and tell them about the theft. Come on. He's a 28-year-old man. You don't need to contact his parents for shit. Contact the police and report the patient. He already said they found out. They found out at work, right? And you're just going to believe him. Your job is not to report this. This is not a reportable offense that you need to report. As a doctor, no. As a doctor, you need to report if someone has killed somebody, may kill somebody, or if they have some of those STDs that are reportable, or any disease that is reportable. And then F, prescribe methadone for the patient's opiate addiction. Well, if he wants that, if he wants help with his addiction, maybe. But see, that's where A comes to the correct answer. Discuss treatment options and a referral for a detoxification program. After that, if he wants it, then you prescribe shit. Right? It's the only answer choice that makes sense or has any rational logic to it, and it sounds the best. Discuss treatment options. That's your job as a doctor. That's the only one in this list of answer choices. That is your job as a doctor. 123. A 29-year-old woman comes to a physician because of irregular menstrual periods since menarche at the age of 12. She is 5 feet 3 and weighs 190 pounds. BMI is 34. She is evaluated and the diagnosis of polycystic ovarian syndrome is made. After explaining the diagnosis, the physician discusses behavioral changes, including dietary modification and exercise as part of her treatment. Which of the following is the most likely to result in patient adherence to this plan? So this I wrote here, very tough question, right? I actually took a long time with this question because in the same NBME, there was another question where referring to a patient support group was pretty helpful. So I was trying to see if this was another one where maybe they want me to refer to a support group again. But I was really caught between D and E. Provide follow-up appointments to assess the patient's progress in attaining her goals. Follow-up appointments are always the correct answer, as far as I've seen, for step 1, right? It's almost never been the wrong answer choice to give follow-up appointments. In addition, support groups are something you give to people who have diseases that have heavy emotional impact, psychological impact, or addiction, right? Something like that. And the other question we had done, I think it was a question about lupus or something. I forget what it was. It was in the same NBME. That patient did need a support group because she needed to make some lifestyle changes that were densely related to her disease. So she needed to find some friends that were also coping with the same disease she had, right? It would really help her. This patient needs adherence to her plan. The best way to do it would not be any of these other answer choices, but I was also confused between some of these too. A says, ascertain the patient's educational level and provide appropriate publications. Providing publications is dumb. Think about it. When would you ever read a publication your physician gave to you, you're going to go home and toss that aside and just forget it even happened. Ask the patient to bring a family member or a friend next appointment. Silly answer choice. Why would that's just irrelevant. But C seemed pretty logical. Inform the patient of the health consequences of not treating her condition. If you tell me that if I don't take my medication, I'm going to die, that will definitely help me adhere to my plan of medications, no matter how complex it might be. So that definitely felt like an unfair answer choice to have there, but I can see how, D is obviously a better answer choice. Okay? Follow-up appointments will allow me as a doctor to see if this patient is getting better, if she's having any issues, if she has any questions she wants me to answer, because this is all very new to her and she needs guidance. Okay? Young woman with PCOS is very scary. She might not even be able to get pregnant anymore, so there's a lot of things she might have questions for. Follow-up appointments, me as a physician with all my knowledge, I'm going to be much more helpful to her than a support group. She doesn't need emotional support or anything like that. 124. This was really cool. This was an interesting question. So 34-year-old man with physician comes to a physician because of a 3-month history of a progressive rash on his feet. And they give you a picture of it. The rash is not itchy or painful, which was very diagnostic, right? That's a very important thing to tell you. A photograph of the feet is shown. Rapid HIV antibody test result is positive. In addition to treatment with highly active antiretroviral therapy, which of the following is the most appropriate pharmacotherapy for this patient? So I looked at the answer choices, and even I was kind of stumped for a second, a couple seconds, because I was like, is this bacterial? Is this fungal? I'm trying to think of all the bacteria that can cause something like this. Trying to think of all the fungi that can cause all this. And as I'm thinking, I looked at the question, and I saw the rash is not itchy or painful. So if it's not itchy, right, then it's most likely not bacterial or fungal. Okay, it's not. It's not going to be some kind of infection-related stuff. If this was infection, it would be itchy, right? It would have a chance of being painful, but it's not at that. So now we're left with, antihistamine, antiparasitic, antineoplastic. Antiparasitic also gets canceled out. Same thing, you can knock out antiparasitic also because parasitic would also be itchy or painful, right? It's not an infection. That's what I get there. And then I went back to thinking of HIV, and I'm like, what else in HIV caused rashes? And when you think of rashes, you want to think of your dermatology section in first aid. And there was Kaposi sarcoma, and I immediately went with antineoplastic. Because antihistamine, if you need to give somebody an antihistamine, that means the histamine must be there and they would be itchy, or at least painful or warm, something like that. The no itch, no pain really gave away the answer for me. So this patient has HIV and the rash shown is neither itchy nor painful. This usually means it's not due to some kind of infection, so you can knock out A, B, and E. Hence, the only other rash that should come to mind in relation to HIV is Kaposi. This can be related to HHV8 and is similar to bacillary angiomatosis, but Kaposi has lymphocytes. Bacillary angiomatosis occurs in AIDS patients with Bartonella infections from cat scratches, and that is going to have neutrophilic infiltrate, right? But our patient is going to have lymphocytic infiltrate. This is Kaposi sarcoma, page 523. Yeah, Vanessa, I don't blame you. It's definitely one of those questions you can't get wrong, especially based off of what point you're in on your test, what number you're on. And there's a couple of disgusting pictures here, but that's because Kaposi sarcoma on this page is the only thing they didn't give you pictures for in first aid. There are no pictures. But they tell you it's an endothelial malignancy that you can find in the skin, mouth, GIT, respiratory tract, anywhere, right? Related to HHV8 and HIV. Rarely mistaken for bacillary angiomatosis, but this thing, Kaposi, has lymphocytic infiltrate, whereas bacillary angiomatosis, looking like a tomato over here, right? Even in image A, this thing has neutrophils because it's a bacterial thing. Bacillary angiomatosis, Bartonella hanseae. So this image up here is oral Kaposi sarcoma. Okay, so this is really cool. I was like, this has to be shown, so I just put this in the book yesterday. This is a really good picture. You should have it in your mind. You should remember, if you see something like this and the patient is HIV positive, Kaposi, oral Kaposi. This is Kaposi sarcoma all over the body, right? Kind of starting to look like sinus lesser tralata if it was much more. And you can have this anywhere. There was a whole thing, this link over here, I'll share it, showing you how it looks like in other parts of the body as well. So let me skim through that, because you see how they tell you Kaposi sarcoma can also be in the GIT, respiratory tract, so you need to know how that looks too. And I didn't have space to put pictures, but it's okay. It was better to show it here. This is your lung with Kaposi sarcoma. Okay, so they're telling you down here, HIV infection stage C3, Kaposi sarcoma of the right upper and middle lobe and of the para-aortic abdominal soft tissue, right? Generalized CMV infection, pathologically, anatomically detected in lung, blah blah blah. Right? It's just, you can see how like it doesn't look like a healthy normal lung at all. All right, that's one picture. This one here is another picture. Right, visceral involvement of Kaposi sarcoma in AIDS is common. Here are multiple reddish nodules seen over the gastric mucosa. Okay, so that's your gastric mucosa. And the last one, this is your liver. Right, visceral involvement of Kaposi sarcoma. Here you see multiple reddish irregular masses in the liver. Right, this one here, that one there, this over here too. Okay, and then tiny hemorrhage type stuff all over the place. These are all weird images from Utah, med.utah.edu, which you can see on your next NBME for sure, right? They can just take one of these pictures, make a question out of it, and boom, you're going to be like, what the hell is this? If you've never seen this before, if I had never seen this on this page here, I really wouldn't know what this is. I would know it's something metastatic because it's not in one place, it's not solid, but I wouldn't think of Kaposi sarcoma in the liver. Right, so very important to know that first aid really doesn't show you anything for Kaposi sarcoma. No images on this page. So I made sure I showed you all three. This is also Kaposi sarcoma. This one here is on a baby's butt, so that's a strawberry hemangioma, which is going to grow, then regress. This is a cherry hemangioma on older skin, and this just continues. You get one, then you get plenty more. Excuse me. So that's all of that stuff. And then last question for right now, half of block 3 done. 70-year-old man comes to the physician because of skin blistering for 1 week. He has had no oral lesions. Physical exam shows tense bullae in the joint folds of the upper and lower extremities. A biopsy specimen of the skin shows subepidermal blister formations. Direct immunofluorescence microscopy shows antibodies directed against proteins at the dermal-epidermal junction, which is diagnostic of bullous pemphigoid. Which of the following structures is most likely being targeted by the antibodies in this patient? So you're going to be targeting hemidesmosomes at the basal membrane. That's it. So that was answer choice D. Desmosomes or macula adherens are the target in pemphigus vulgaris. Right, so page 525, which is just 2 pages down from here. So this is what we're seeing, right? So this image D is what they told us about. At the dermal-epidermal junction, they saw antibodies. And this is his physical findings. Bullous. Right, a bunch of bulla. They're just, always remember bullous pemphigoid below the epidermis is just fluid-filled things. They can blister. You can rip them and, fluid comes out. But there's a negative Nikolsky sign though. There's no bleeding. Whereas in pemphigus vulgaris, your skin just rips apart, so there is bleeding. You could just rub skin and it comes off. Right? And also, they told you oral mucosa is spared here. So that patient in our question didn't have it. Oral mucosa is involved in pemphigus vulgaris. Right? A lot of cool differences, a lot of really good pictures you need to remember about to really have the differences down. And we've already talked about this when we did the musculoskeletal videos. So that's it for now. In the next video, I'll continue on and go on to the rest of NBME 18 Block 3. And then I'll do another day to finish up Block 4. Thanks a lot for joining, and I'll see you guys later.